Hello and warm greetings to all the judges and viewers. My name is Eshika Dubey. I'm a third year MBBS student from MGM Medical College, Aurangabad. Firstly, I would like to thank the organizers of this competition for coming up with something as exciting, fun, and yet academically inclined as the Dr. Sherlock, the Science of Deduction. So today I'm going to play Sherlock, try to crack down the given case, and come to a diagnosis. And to raise the bar a little, I have actually decided to time myself. So I'm going to try and do it in less than 7 minutes or 7 minutes. So let's go save a life, hypothetically, and let's get started. So this is the case, and let's see what the clinical features are. 65-year-old man presented with right-sided oral fullness. He had decreased hearing on the right side for 2 weeks and complained of popping and clicking on the same side. He had been on fluticasone nasal spray for 1 year and had recently been treated with multiple courses of antibiotics for acute sinusitis. An audiogram demonstrated a 40 decibel right-sided conductive hearing loss. At the initial visit, a laryngotomy was performed on the right side with a large amount of serous fluid being evacuated. He has intermittent nosebleeds, so epistaxis, right-sided tinnitus, right neck pain, and no history of dysphagia, odonophagia, dyspnea, fever, chills, night sweats, weight loss, or head and neck surgery. Also, there are complaints of physical-sided tactfulness and lymphadenopathy in the posterior cervical triangle upon palpation. Flexible nasopharyngoscopy was performed, showing a lesion in the fossa of Rosenmuller extending anterior to the right torus tubarius that appears suspicious. So the clinical features of this patient are right-sided oral fullness, conductive hearing loss. There was acute sinusitis for which treatment has been given to him in the past. Serous fluid has also been evacuated. Epistaxis, tinnitus, neck pain, right-sided neck fullness, lymphadenopathy in the posterior cervical triangle, and lesions in the fossa of Rosenmuller, and the CT scan shows involvement of right maxillary sinus. There's this dialogue by Sherlock Holmes which says that when you eliminate the impossible, what remains, no matter how improbable, must be the truth. So, we'll eliminate these conditions one by one, and that should probably lead us to our probable diagnosis. So, speaking of the first condition, I don't think it can be lymphoma because lymphomas are supposed to be relatively huge. And one peculiarity about lymphomas is that they do not invade their adjacent structures. However, here we have seen that there is spread towards the posterior cervical triangle and the right maxillary sinus. So, it cannot be a lymphoma according to me. Moving on, I think it cannot be an angiofibroma because angiofibroma is most common in adolescent males due to the effect of testosterone. Our patient is a 65-year-old male, so it does not occur in old ages. And also, its presentation is usually pinkish, purplish, lobulated sessile mass. So that's how it is usually presented. So again, I think angiofibroma can be ruled out very well. It should not be a squamous papilloma because it presents as a pale polyploidal mass. That is the peculiar presentation of squamous papilloma. So again, it cannot be a squamous papilloma according to me. Eliminating thorn wall cyst should be very easy because thorn wall cyst usually presents with a dull occipital kind of an headache, and also along with postnasal discharge there is crust formation. So these two things were not presented in our patient, so it can be eliminated very easily. I would like to eliminate nasal polyp as well because nasal polyps are usually visible. They are huge masses in the nasal nares and near the nasal septum. So there were no such masses present in our patient. So again, it cannot be a nasal polyp. And rhabdomyosarcoma again is not a possibility because it is a disease of children and our patient is a 65-year-old patient. So then again, it cannot be rhabdomyosarcoma. So looks like we are left with nasopharyngeal carcinoma. Let's compare the condition and the given case. So first is the presence of serous otitis media, that is unilateral. So it is it is seen in about 70% of the cases. It is the most common feature of nasopharyngeal carcinoma. Second is conductive hearing loss, which is due to serous otitis media. So again, our patient has a conductive hearing loss, and nasopharyngeal carcinoma has one of its major features as conductive hearing loss. Next is involvement of fossa of Rosenmuller. Yes, nasopharyngeal carcinoma does in fact actually start from the fossa of Rosenmuller. So that. Fourth, epistaxis. Our patient has epistaxis definitely. So next is the involvement of the lymph nodes of the posterior cervical triangle. So lymphadenopathy and associated neck fullness and neck pain. So these all features point towards nasopharyngeal carcinoma. They give away the most common and obvious hints for why this patient is a patient of nasopharyngeal carcinoma. So yeah, my probable diagnosis would be nasopharyngeal carcinoma. I believe that is what it should be. Coming to the management part, the management of nasopharyngeal carcinoma cannot be surgical because surgery requires for the organ to be cut open and it should be exposed, but the margins of the pharynx, nasopharynx exclude that option. So the only options are radiation for stage 1 and 2, and concurrent chemoradiation for stage 3 and 4. Concurrent chemoradiation is of course mixing chemotherapy and radiotherapy, simultaneously mixing this. So that is what concurrent chemoradiation is, and these are the choices of management. Other facts about nasopharyngeal carcinoma are that it is also known as Guangdong Syndrome. It is most common in the Southeast Asian countries like India, Pakistan, China, Japan, Mongolian population. Its etiological factors are genetic factors, Epstein-Barr virus, and nitrosamine and salt. It causes eustachian tube blockage, which results in serous otitis media, which is the most important feature. It can spread intracranially and affect the trochanteric triad and the sinus of Morg agony. It can spread to the paranasal sinuses and result in Horner's syndrome. Then it has bimodal age occurrence. Its prognosis is poor because its presentation is very late. It is a radiosensitive tumor, and yeah, that's about it. So thank you very much.